Dear student, the topic of this video is the glomerular filtration rate or GFR. Learning objectives. At the end of this session, the student will be able to define GFR and give its normal value, list the factors that affect GFR, explain the mechanism of glomerular filtration, list the conditions that regulate GFR, understand the mechanism of regulation of GFR. Definition and normal value of GFR. GFR or glomerular filtration rate is the amount of plasma ultrafiltrate formed in kidneys per unit time. The GFR in a healthy adult of average size is approximately 125 ml per minute or 7.5 liter per hour or 180 liter per day. Magnitude of GFR correlates fairly with surface area. GFR is 10% lower in females than males even after correction of surface area. So we can see from this picture that is GFR is, or the glomerular filtration rate, it is around 180 liter per day. But the amount of urine that is produced per day, it is only 2 liter per day. So from this it is clear that is huge amount of reabsorption of fluid will take place so that from 180 liter it can be reduced to 2 liter. So we can say the rates at which the different substances that are excreted in the urine, the amount that will be excreted, that excretion rate, it will actually depend upon three renal processes. One is the process of filtration or the glomerular filtration. Second is the process of reabsorption. And third is the process of secretion. And these three things will determine how much will be excreted as urine. So from this level we know that there is huge amount of filtrate produced by the nephron, that is around 180 liter per day. So why are large amounts of solutes are filtered and then reabsorbed by kidneys? So 180 liter per day is produced, then huge amount has to be reduced and reabsorbed, and only 2 liter will be excreted in urine. So why not a small amount of GFR is produced and that is excreted in urine? So one advantage of high glomerular filtration rate is that it allows the kidneys to rapidly remove waste products from the body that depend mainly on glomerular filtration for their excretion. So kidney is the organ that is responsible for elimination of so many toxic substances from our body. So suppose there is any increase in the toxic substance in our body, it can be very readily, very rapidly excreted out through the kidney, and this is facilitated by the high glomerular filtration rate. Most of the waste products, they are very poorly reabsorbed by tubules. So once filtered, so they will be excreted out and therefore depend on a high GFR for effective removal from the body. Now the second advantage of a high GFR is that it allows all the body fluids to be filtered and processed by the kidneys many times each day, because the entire plasma volume is only about 3 liters. We know that 5 liter is a cardiac output and the plasma volume is around 3 liter. Whereas the GFR, I have already told you, it is 180 liter per day. That means the entire plasma can be filtered and processed about 60 times each day. This high GFR allows the kidney to precisely and rapidly control the volume and composition of body fluids. From the functions of the kidney, we know that it maintains the electrolyte balance, it maintains the acid-base balance. So this mechanism of maintenance of electrolyte and acid-base profile of the body, it attributes to this high GFR. Now, renal handling of substances, if we look into it, we'll see that there may be 4 types of handling of the substances by kidney. First, this one. So this is freely filtered. We can see that it is freely filtered, but it is not reabsorbed and not secreted. So we can say that the excretion rate, it is equal to the filtration rate. In the second picture, we can see the substance is freely filtered, but it is partly reabsorbed. So we can say that the rate of excretion, so the amount that is excreted, it is less than the amount filtered. Now in the third case, we can see the substance is freely filtered, but it is fully reabsorbed. So there is no excretion, although it is filtered, but there is no excretion of this substance. And the fourth type of handling, it is freely filtered and it is also secreted from the peritubular capillary blood to renal tubules. What happens due to this? The rate of excretion, we can see that the excretion amount, it is greater than the rate of filtration. Now come to the measurement of GFR. So GFR can be measured on the basis of the principle of renal clearance. So what is renal clearance? Renal clearance is the volume of plasma from which a substance is completely removed or cleared per unit of time. Suppose this is plasma, we know so many solutes are there. So I am taking one solute. So the volume of plasma, suppose it is coming out through this tap. So the volume of plasma that is cleared, so through this tap, it can excrete or it can eliminate the solute. So the volume of plasma that is completely cleared from this specific solute per unit time is known as the renal clearance. So suppose we are taking a bottle like this which has got a filter here. So and this fluid is passing through this filter, and after filtration, these solutes are excreted out and the plasma is going back, or the fluid is going back into the bottle. So we can say from the definition of clearance that the rate of elimination, so rate of elimination of these solutes, it depends on the volume of liquid flowing through the filter per unit time. So the volume of liquid that is flowing through the filter per unit time, it is the clearance, and it will also depend upon the concentration of the substance in the liquid flowing through this filter. So two factors are responsible for determination of the rate of elimination of solute. One is what is the volume of the liquid that is flowing through the filter per unit time. Another is the concentration of this substance in the liquid flowing through the filter. So one is the clearance. So we can say the rate of elimination is equal to clearance into times the concentration of the substance. Now in our body, where lies this filter? So we know that when we are talking about kidney and we are talking about the filtration barrier, so our filtering membrane is our glomerular filtration barrier or glomerular capillary membrane. So this is our filtration slit or filtration barrier through which type of fluid is passing? So through which the plasma, the blood plasma is passing through this. So we are replacing, in the previous picture we have seen a filter, we have seen a fluid containing solute is passing through that filter. If we apply this theory into our kidney, so we will see that this filter is nothing but our glomerular filtration barrier, and the fluid that is passing through it is nothing but the plasma. So we can replace this equation now. So we can say that the rate of elimination now, it depends on the volume of, instead of the fluid we are writing the plasma, the volume of plasma flowing through the filter per unit time. So it is equal to GFR, we can call it. And concentration of the substance in the plasma flowing through the filter, that is a plasma concentration of this subject. So we can say that the rate of elimination is equal to, we knew that it is clearance into C. Now we are replacing it with GFR and the plasma concentration. Now this clearance, it can be replaced by GFR in very specified condition. What is that? We know that from this picture that it is not always true that the amount that is filtered, it will be totally eliminated by the urine. So if we want to replace the clearance via GFR, we have to select such a substance where the rate of elimination, it is just equal to the rate of filtration. So we have to consider this situation only. But if there is partial reabsorption or total reabsorption or secretion of substances into the tubule, then we cannot replace the GFR, we cannot replace clearance with GFR. So for the measurement of GFR, we require a substance that should be freely filtered. It should be neither reabsorbed nor secreted by the tubule. It is non-toxic and it should not be metabolized by the body. So if a substance can fulfill all these criteria, then only we can use it to measure the GFR. Such a substance, example of such a substance is inulin. It is a polymer of fructose that has the molecular weight of 5200. Now if we are using inulin for the measurement of GFR, so we know that amount filtered should be equal to the amount excreted. So we can replace the clearance with GFR, that into the plasma concentration of inulin, that should be equal to the rate of elimination. So rate of elimination will be nothing but the urine concentration of the urine and the urine flow rate, that is amount of the volume of urine flowing per minute. So suppose the plasma concentration of inulin, it is 1 milligram per ml. In that case, if we measure the urine concentration of inulin, it is 125 milligram per ml, and the flow rate of urine, if it is 1 ml per minute, if we put this value, we will get the GFR, that is exactly the value of it, it is 125 ml per minute. So the inulin, it can be used to measure the GFR because inulin is an ideal glomerular marker and inulin clearance is an accurate marker of GFR. So these can be proved by these three tests. So if we know that GFR into the plasma concentration of inulin, so this is the amount of filtered, that is equal to the amount excreted, that is the urine concentration of inulin into the urine flow rate. Now, assuming GFR does not change, in the first picture, I am plotting this rate of inulin excretion. I am plotting the rate of inulin excretion in the y-axis, and I am seeing the relationship of this with the plasma concentration of inulin. And we will see that the plasma inulin concentration, it is directly proportional or we can say the excretion rate of inulin, or the inulin excretion rate, it is directly proportional with the plasma concentration of inulin. As we are increasing the plasma concentration, there is gradual increase in the excretion or elimination rate of urine. In the second set of tests, we are plotting the clearance of inulin, that is the urine concentration into the urine flow rate divided by the plasma concentration of inulin, that is the clearance. So we are plotting this along the y-axis, and along the x-axis we are plotting the plasma concentration of inulin. From this picture we can say that inulin clearance is independent of the plasma inulin concentration. So it is a line like this. So inulin clearance, it is totally independent of the plasma concentration of inulin. In another picture we are plotting this inulin clearance with the urine flow rate. Here also we can say that inulin clearance is independent of urine flow. So from this we can say that inulin is an ideal glomerular marker and inulin clearance is an accurate marker of GFR. Now from this table we can see that the normal clearance value of different solids. So if the clearance of a substance is equal to GFR, so we can say that here we can see the clearance of inulin, it is exactly same with the GFR. So we can say that if the clearance of a substance is equal to GFR, it is the first condition, so the substance is neither reabsorbed nor secreted by the tubule. So example is inulin. Another example you can take, the example of glucose, where clearance is 0. So if the clearance, it is less than GFR, that means there is net reabsorption of the substance. The example is glucose. Another condition we can see, that is the para-aminohippuric acid. Here clearance value is 560 ml per minute, much greater than the value of GFR. So in case of para-aminohippuric acid, we can say if clearance of a substance it exceeds the GFR, then there is net tubular secretion. So the example is para-aminohippuric acid. So we all know from my previous video, the para-aminohippuric acid is used for the measurement of renal blood flow. Another important dynamic of para-aminohippuric acid transport is that when para-aminohippuric acid concentration, plasma concentration of para-aminohippuric acid is very low. So this is a plasma concentration. So if it is very low, so we can find the clearance of para-aminohippuric acid is very high. But as we are gradually increasing the para-aminohippuric acid concentration in the plasma, so when it rises above the transport maximum of para-aminohippuric acid, we can see there is a fall of clearance of para-aminohippuric acid. So it is falling, and it is falling progressively, and eventually it approaches the clearance of inulin. So this is the clearance of inulin. We know that this clearance is not dependent on the plasma level of inulin, so it is like that. But in case of para-aminohippuric acid, when its plasma concentration is very less, so the clearance is very high. As we are gradually increasing the plasma level of it, so there will be very rapid drop of this clearance value, and it will approach the level of inulin. So that is why for the measurement of renal plasma flow, we usually give para-aminohippuric acid at a very low dose, so that by a single circulation 90% of it can be excreted out and we can measure the renal blood flow. Conversely, we can see here another finding, that is the clearance of glucose. It is essentially zero. We know that clearance of glucose, it is zero at plasma glucose level below renal threshold. But above that threshold level, you can see the clearance of glucose, it is rising. So in case of para-aminohippuric acid, as the plasma para-aminohippuric acid level is rising, its clearance is decreasing. Whereas in case of glucose, we can say beyond the renal threshold value, the clearance of glucose, it is rising, and it is rising and approaching towards the clearance of inulin. So these are the two finding we can see from this graph. Very important finding. Now clearance of another substance that is very useful, we can see from this graph, that is the creatinine clearance. So it is almost near to the inulin clearance and almost near to the glomerular filtration rate value. So it is creatinine, it is secreted by tubules. Thus clearance of creatinine, it is not exactly same as GFR. So it is slightly higher than the inulin because some amount is secreted. Now in spite of this, clearance of endogenous creatinine is a reasonable estimate for GFR, as the values agree quite well with GFR values measured with insulin. So although inulin clearance is the most reliable method for measuring GFR, so clinicians usually they do not prefer inulin for the measurement of GFR, because inulin has to be injected and it has to be given by intravenous infusion. Now this problem can completely be avoided if we use endogenous creatinine, which has inulin-like properties. So creatinine is such a substance and its clearance is a reasonable estimate of GFR in humans, but not all species. Tubules to variable degrees secrete creatinine, which by itself would lead to an 20% overestimation of GFR in humans. However, because commonly used colorimetric methods overestimate plasma creatinine concentrations, the calculated creatinine clearance turns out to be close to the inulin clearance. Thus, the effects of these two errors, that is a tubule secretion and overestimated plasma levels, tend to cancel out each other. So from this equation we can say that GFR, it is expressed by, first it is the amount excreted, that is urine concentration, and the urine flow rate divided by plasma concentration. As inulin is secreted by the tubules, so this value is a bit high. Okay, but in the colorimetric method by which we measure the creatinine clearance, this colorimetric method, it also overestimates this plasma concentration of creatinine. So the value, this is the elimination of creatinine, it is overestimated because some amount of creatinine is secreted. This value, that is the plasma concentration of inulin, it is also overestimated by the colorimetric methods. So these two factors, these two errors, one is the denominator, another is in the numerator, they will cancel each other and ultimately we will get a result that is almost near to the actual value of GFR. So in clinical practice, determining the creatinine clearance is an easy and reliable means of assessing GFR, and such determination avoids the need to inject anything into the patient. One merely obtains samples of venous blood and urine, analyzes them for creatinine concentration and makes a simple calculation. So this is the uncorrected creatinine clearance we can measure the urine creatinine value, serum creatinine value, urine volume, and the collection time. So this is a corrected version. If we multiply it by 1.73 divided by body surface area, so we will get more actual value of GFR. This is another value which can be calculated, that is the Cockcroft-Gault formula for estimating creatinine clearance. If we know the age of the subject, if we know the body weight of the subject, if we know the serum creatinine level, then we can very easily calculate the creatinine clearance. In case of female, we have to multiply it by 0.85. Now clinicians, they use, in addition to the creatinine clearance, plasma concentration of creatinine is also a very good indicator of GFR, how the kidney is functioning, whether the filtration is well or not. So the plasma concentration of creatinine, it is also a very good indicator of that. So from this curve we can say that the plasma concentration of creatinine and the creatinine clearance, that is the GFR, it is equal to the amount that is excreted out. It is constant. This is constant. So in a healthy individual, so if the GFR is 100 ml per minute, so its clearance, that means this factor is 100 ml per minute, and if the plasma concentration of creatinine is 1 milligram per deciliter. So we can say 1 milligram per deciliter means 1 milligram per 100 ml into the 100 ml per minute. So we get a value of 1 milligram per minute, that is the rate of excretion of creatinine, and this is constant. Now if the patient is suffering from renal disease and the GFR is suddenly drops from 50 ml per minute, so this factor has been reduced to half, from 100 ml to 50 ml. So in order to keep it constant, so naturally the plasma concentration of creatinine should be high. So if it is reduced to half, from 100 it has become 50, so we must increase the plasma concentration, we must double it. So plasma concentration of creatinine, which was initially 1 milligram per deciliter, it will become 2 milligram per deciliter, so that if we multiply this 2 milligram per deciliter with the 50 ml per minute, we are getting the same constant value of elimination, that is 1 milligram per minute. So similarly, if GFR it has to fall 1/4 of this value, so the plasma creatinine level would rise to 4 milligram per deciliter. So if there is decrease in the function of kidney, decrease in GFR, that will be clearly indicated by increase in plasma concentration of inulin, plasma concentration of creatinine. Now this is very clearly visible from this rectangular hyperbola structure of this graph. Now mechanism of glomerular filtration. So glomerular filtration, we can say that the factors governing the filtration across the glomerular capillaries, they can be explained by this equation. For every nephron, the GFR, it will depend upon the Kf, that is the glomerular ultrafiltration coefficient. It is a product of the glomerular capillary wall hydrolyte conductivity, that is the permeability of the membrane, and the effective filtration surface area. Now come to the PGC. This is the mean hydrostatic pressure of the glomerular capillary. Then is the PT. It is the mean hydrostatic pressure in the tubules or the Bowman space. Then pi GC. It is the oncotic pressure of the plasma in the glomerular capillaries, and the pi T, it is the oncotic pressure of the filtrate in the tubule or in the Bowman space. So from this equation, it is very clear the factors that favor that favor the filtration are two. One is this is the glomerular capillary hydrostatic pressure. Another is this one, that is the Bowman's capsule or tubular oncotic pressure. Whereas the forces or the factors that oppose the glomerular filtration are these two. What are they? One is the hydrostatic pressure. One is the hydrostatic pressure at the Bowman's capsule, this one. Another is the oncotic pressure of the glomerular capillary. So they are trying to move the fluid away from the Bowman's capsule towards the glomerular capillary. Whereas the hydrostatic pressure of the glomerular capillary, it is trying to move the fluid from the glomerular capillary to the Bowman's capsule. It is helping in the formation of filtration. So we can say the capillary hydrostatic pressure, that is PGC, is opposed by the hydrostatic pressure in the Bowman's capsule. We know that PGC, it is opposed by the hydrostatic pressure in the tubule, and it is also opposed by the oncotic pressure gradient across the glomerular capillary, that is PGC minus pi t, PGC minus pi t. The pi t is normally negligible. So we all know that the oncotic pressure, it actually depends upon the protein, plasma protein level. So most of the protein, it remains entrapped within the glomerular tuft. Very nominal, no protein, it actually enters into the Bowman's fluid. So we can say that this factor, that is the oncotic pressure of the Bowman's capsule, it is Bowman's space oncotic pressure, it is almost negligible. So that we are getting the resultant force, which if we remove this factor, we can have these three forces are acting or helping for the glomerular filtration. One force that is helping the GFR is the PGC, that is the hydrostatic pressure of glomerular capillary. The other two forces that is preventing the formation of glomerular filtrate are the hydrostatic pressure of the Bowman's capsule and the oncotic pressure of the glomerular capillary. Now the pressure in the glomerular capillaries, it is higher than the other capillary beds. We can say that glomerular capillary has got some very specific features than other capillaries. So they have very high pressure than the other capillary beds, and this is due to the afferent arterioles. These afferent arteriole and efferent arteriole, their diameter usually varies, and these afferent arterioles are short and straight branches of interlobular artery. This is the one reason why the pressure in the glomerular capillary is higher. Furthermore, the vessels downstream, that is this efferent arteriole, it has a very relatively high resistance. So this is responsible for some specific features of glomerular capillaries. Now what are those features? Glomerular filtration, it takes place throughout the entire stretch of the glomerular capillary. We can say it is happening, you can say that the filtration is happening. So this is the direction of filtration. So filtration is happening along the entire length of the glomerular capillary, unlike other capillary beds, where we can see that at the proximal part, here at the arterial end, and at the proximal part, the direction of force is in this direction, that is filtration is happening. Whereas in the distal part, the direction of force is in this direction, so it is facilitating the absorption. So fluid is moving in other direction. But in case of glomerular capillary, the direction of filtration force is always towards the Bowman's capsule. So the filtration is taking place throughout the whole stretch of glomerular capillary. Now this is caused by the high resistance of the narrower efferent arterioles, which do not allow the filtration force to fall along the length of the capillaries. Now, under normal circumstances, we can say, under normal circumstances, what are the forces at different level of glomerular capillary? We can say that at the afferent end of glomerular capillary, the PGC value, it is 45, and at the afferent end, the hydrostatic pressure of the Bowman's capsule, this value is 10 mm of mercury. And what about the oncotic pressure of the glomerular capillary at the afferent end? It is around 20. So the net filtration force, we can say, it is 15 mm of mercury at the afferent arteriolar end. Now, as the blood proceeds through the glomerular capillary towards the efferent end, so as the blood proceeds from afferent towards the efferent end, the rapid filtration of fluid leads to a gradual increase in the colloidal osmotic tension or oncotic pressure. So we can say that at the efferent end, the hydrostatic pressure is same as the afferent end, it is 45. The hydrostatic pressure of the Bowman's capsule, it is also same, it is 10 mm of mercury. The change that is occurring, it is at the oncotic pressure of the glomerular capillary. From 20, it is becoming 35. The rapid filtration of fluid leads to a gradual increase in the colloidal osmotic tension of capillary blood. So ultimately, a point will be reached where the filtration stops as the net filtration pressure becomes 0. So we know that along this pathway, the oncotic pressure of the glomerular capillary is gradually increasing. There will be a point where it will just attain its optimal value, where there will be the filtration force will be 0 and the filtration will stop. So this is why we can say that if the renal blood flow increases, so this point where this filtration stop, this point, if we increase the renal blood flow, this can be pushed more towards the efferent arteriole. So we can increase the surface area for filtration if the renal blood flow or renal plasma flow, it is increased. This is why GFR increases with increase in renal blood flow, and this exchange across the glomerular capillary is flow limited rather than diffusion limited. As we are increasing the flow, we can increase the filtration. That's why it is flow limited. Now, factors affecting glomerular filtration rate. So the two major factors from the equation of GFR, we know that the filtration, it depends upon two factors. One is the factor that is the capillary filtration coefficient Kf, that this is the factor related to the membrane itself. Another is the net filtration force. It is the sum of forces acting across the membrane. So factors related to the membrane itself and the sum of the forces acting across the membrane, these two things will determine affect the glomerular filtration rate. So first we'll concentrate on this Kf or the capillary filtration coefficient. It will depend upon two factors. One is the permeability of the membrane, another is the filtering surface area. So what membrane? Obviously it is our glomerular filtration barrier across which the filtration will take place. From my previous video, I think you came across the detailed structure of this glomerular filtration barrier. So glomerular filtration barrier has got three layers. One is the capillary endothelium. It has its special quality is that it is very much porous or fenestrated, and the diameter of this pores is around 70 to 90 nanometer. Then we have the glomerular base membrane, and then we have the Bowman's capsule epithelium, which has got very specialized cell, that is the podocytes. These are the food processes of the podocytes, and the gap in between is known as the fenestration or filtration slit. The diameter of this fenestration slit or filtration slit, it is around 25 nanometer. They will be covered by a diaphragm known as the slit diaphragm. So the filtration across this filtration barrier, it will depend upon the size of the particle, shape of the particle, and the electrical charge of the particle. So effect of molecular size on the filterability. So filterability of the solute is inversely related to their size. That means if the size is increased, the filterability will be decreased. Now this table, it lists the effect of molecular size on filterability of different molecules. A filterability of 1. So filterability of 1, that means the substance is filtered as freely as water. And a filterability of 0.75, that means the substance is filtered only 75% as rapidly as water. Note that electrolytes such as sodium and small organic compounds such as glucose, sodium, glucose, they are very freely filtered. Now as the molecular weight of the molecule, it approaches the albumin, you can see here the filterability rapidly decreases. It is seen that neutral substances with a diameter less than 4 nanometer are freely filtered, and the substances with diameter of more than 8 nanometer are not filtered. Regarding the shape of the particle, the elongated particle with large molecular weight can pass easily, whereas globular particle of same molecular weight cannot pass through. Now, effect of charge on filterability. The glomerular filtration barrier, it consists of 3 elements: endothelial cells, glomerular basement membrane, and the epithelial podocytes. The later 2 layers, that is the glomerular basement membrane and the podocytes, they are covered with negative charges due to the presence of this heparin sulfate, proteoglycans, and sialoproteins. So we can say that as they are negatively charged, so albumin, although the molecular diameter of it is 6 nanometer, and we know the pores, they can accommodate up to 8 nanometer particle, but the albumin cannot pass through the glomerular capillary membrane because of its negative charge and the electrostatic repulsion exerted by the negative charges on the glomerular capillary wall. So this figure shows how electrical charge affects the filtration of different molecular weight dextrans by the glomerulus. So dextrans are the polysaccharides that can be manufactured as neutral molecules, as the anionic molecules containing the negative charge, and the cationic molecules. So we can have the neutral dextran, anionic dextrans, and the cationic dextran. Now anionic dextrans are restricted from filtration, whereas cationic dextrans pass more rapidly into the filter. So we can say, see here the clearance ratio. So the cationic dextran, they can pass more easily. Their clearance ratio is very high, whereas the anionic dextran, their movement is restricted. Now for negatively charged dextran or the anionic dextran, the relationship between charge and the filterability is characterized by a left shift of the curve. So this is the curve for the neutral dextran. If we make this dextran negatively charged, we can say that the curve is shifted to the left. That means for a same molecular weight, the filterability is reduced. And the opposite thing will happen. It is true for the positively charged dextran. Now in certain kidney disease, the negative charges on the glomerular basement membrane, it is lost. For example, the minimal change nephropathy. As a result, albumin is filtered and appear in urine, and a condition known as proteinuria or albuminuria. Now, size of the capillary bed can affect the GFR. The surface area for filtration of the capillary bed depends on the size of the mesangial cells. So, these are the mesangial cells. The contraction of mesangial cells decreases the area available for filtration. If they contract, so surface area available for filtration will be reduced, whereas relaxation of mesangial cell increases the area for filtration. Thus, mesangial cell contraction impairs GFR and relaxation facilitates GFR. Now, these are the factors affecting GFR. We have already discussed the factors that is related to membrane, that is related to the permeability coefficient Kf, and changes in the glomerular capillary permeability and changes in the effective filtration surface area. Now, we want to deal with the factors or the force that is dealing with the net filtration force. That is, we want to know the effect of glomerular capillary hydrostatic pressure on GFR, effect of hydrostatic pressure of the Bowman's capsule on GFR, as well as the effect of systemic blood pressure on the GFR. So, how this filtration force, their change is affecting GFR, this is our point of interest. So, from our previous knowledge, we know this is the equation where the factor that is favoring the filtration is 1. This is the hydrostatic pressure of glomerular capillary. As this factor is very negligible, we are not taking it. And factors, those oppose the filtration are 2. That is the hydrostatic pressure of the Bowman's capsule and oncotic pressure of the glomerular capillary. So, it is obvious if there is increase in the hydrostatic pressure of the Bowman's capsule, so it is an opposing force, so there will be reduction in GFR. When it will happen? When there will be increase in the hydrostatic pressure of Bowman's capsule, it may happen in urinary tract obstruction, for example, kidney stones. Similarly, if the oncotic pressure of the glomerular capillary is increased, there will be reduction in GFR. It happens when there is increased plasma proteins and decrease in renal blood flow. Now, how this hydrostatic pressure of the glomerular capillary is affected by different other factors in our body, that we want to know. Now, this PGC or the glomerular capillary hydrostatic pressure, if it is increased, so it will increase the GFR. Now, what are the factors that is affecting this PGC or the hydrostatic pressure of glomerular capillary? It is affected by mostly three factors. One is the arterial pressure, that is the blood pressure, and is the afferent arteriolar resistance and the efferent arteriolar resistance. So, arterial pressure, if we look into the relationship of the renal arterial pressure and the GFR and also with the renal blood flow, we can see that within a normal physiological range of blood pressure, that is even from 90 to 20 millimeter of mercury of perfusion pressure, the change of blood pressure is not going to affect the GFR and the renal blood flow. So, it will be maintained within its normal value via the mechanism of autoregulation. So, arterial pressure within a normal physiological range has got little effect on the GFR. Now, but these two factors, that is the afferent and efferent arteriolar resistance, they have very important things to do with the glomerular hydrostatic pressure. So, the PGC, it depends on the renal microvasculature has two unique features. First, this vascular bed has two major sites of resistance control, the afferent and the efferent arterioles. Second, it has two capillary beds in series, the glomerular and the peritubular capillaries. As a consequence of this unique architecture, the significant pressure drops occur in both arterioles. Glomerular capillary pressure is relatively high throughout, and peritubular capillary pressure is relatively low. So if we look into the pressure here, we can see the renal artery pressure is quite high, but there is very sharp drop of pressure in the afferent arteriole. Then the glomerular pressure, it is maintained. Then again a sharp drop of pressure in the efferent arteriole, and the peritubular pressure is very less. Now selective constriction or relaxation of the afferent and efferent arterioles allows for highly sensitive control of the hydrostatic pressure in the intervening glomerular capillary and thus of glomerular filtration. So from this picture we can say afferent and efferent arteriolar resistance control both the glomerular plasma flow and glomerular filtration rate. Now this figure shows the constriction of the afferent arteriole. Suppose this afferent arteriole is constricted, so there will be increase in the afferent arteriolar resistance. As expected with any arteriolar constriction, the renal plasma flow will be decreased. That we can see here from the afferent arteriolar resistance. This blue one is our renal blood flow. It has been decreased with increasing afferent arteriolar pressure. And GFR, what will happen to the GFR? GFR also decreases because as less amount of blood flows into the glomerular capillary, the hydrostatic pressure of glomerular capillary will be reduced and reducing net ultrafiltration pressure. So if the afferent arteriolar constriction is there, both reduction of GFR and the renal blood flow will take place. So we can see from this picture the renal blood flow and GFR both are decreased. Now the example includes the effect of sympathetic nervous system. We know so many neurotransmitters will be released when the sympathetic system is stimulated, and a high level of angiotensin II. This is very important, not the low level. High level of angiotensin II is also going to cause this effect, that is constriction of afferent arteriole and reduction of both GFR and renal blood flow. Now come to the next condition, the constriction of the efferent arteriole, in which efferent arteriolar resistance increases. What is its effect on renal plasma flow? It is the same as with the constriction of afferent arteriole. That is, there will be reduction in renal blood flow. So this blue one, you can see as we are increasing the efferent arterial resistance, reduction in renal blood flow. Yet the effect on GFR is opposite. You can say that GFR will be increased here. Up to a certain level, the GFR, until and unless the renal plasma flow is very less, so the GFR is increased because the blood is restricted from leaving the glomerular capillary. As a result of that, the hydrostatic pressure of glomerular capillary will be increased and net filtration force will be increased. And the example of this situation is if there is low level of angiotensin II in our blood, so that will cause, preferentially it will cause the efferent arteriolar constriction. In that case, the GFR will be maintained but the renal plasma flow will be reduced. So from this figure, we can have another idea of a factor, that is our filtration fraction. We know that filtration fraction is the ratio between the GFR and the renal plasma flow. So when there is constriction of the afferent arteriole, both the renal plasma flow and the GFR both will be decreased. So the filtration fraction will be unaltered. There will be no change. Now when there is constriction of the efferent arteriole, the renal plasma flow is decreased but the GFR is increased. As a result of this, the filtration fraction is increased. Now increase in plasma protein concentration. Plasma protein concentration means we are increasing the glomerular oncotic pressure of the glomerular capillary. That means it will reduce the GFR. It is opposing force of the filtration, so it will reduce the GFR, and obviously the filtration fraction will be reduced. And when there is constriction of ureter, that means hydrostatic pressure of the Bowman's capsule is increased. That means there will be reduction in GFR, and obviously the filtration factor will be reduced. Now, regulation of GFR. GFR is mostly regulated by three factors: neural, hormonal, and the autoregulation. Neural regulation of GFR, kidneys are supplied by sympathetic autonomic nervous system fibers that release norepinephrine. Norepinephrine causes vasoconstriction through the activation of alpha-1 receptor, which are particularly plentiful in the smooth muscle of afferent arterioles. But at rest, sympathetic stimulation is moderately low. So the afferent and efferent arterioles are dilated and renal autoregulation of GFR prevails. But with moderate increase in the sympathetic stimulation, both afferent and efferent arterioles constrict equally, decrease the GFR equally. With extreme sympathetic stimulation, for example, hemorrhage, exercise, vasoconstriction of afferent arteriole will reduce the GFR. Now the hormonal factors. We can say that norepinephrine, epinephrine and endothelin, these factors, they will cause the constriction of renal blood vessels and they will reduce the GFR. Whereas angiotensin II, it will preferentially constrict the efferent arterioles in most physiological conditions. So at low level of angiotensin II, it has large constrictor effect on efferent arteriole and small constrictor effect on the afferent arteriole. As a result, renal plasma flow will be reduced and GFR will be raised. Now at higher concentration, for example in hemorrhage, there will be pronounced constrictor effect on the efferent and medium effect on afferent. As a result, the renal plasma flow will be profoundly reduced, whereas there will be moderate reduction in GFR. Now thus, with both low and high levels of angiotensin II, because of its preferential effect on efferent arteriole, the GFR is protected or it is preserved in setting of vasoconstriction. Now if we use angiotensin converting enzyme inhibitor, this is a drug commonly used in hypertension. So these ACE inhibitors, they blocks the production of angiotensin II and they eliminates its protective effect. This protective effect on GFR, it will be eliminated. Now the another effect of angiotensin II is that as it increases the glomerular blood pressure and filtration, and as the afferent arteriolar constriction is increased, so there will be reduced resistance. So there will be reduced blood pressure in the peritubular capillary and it reduces the resistance of tubular reabsorption. So filtration is GFR, it is maintained and the tubular reabsorption will be very high. As a result, the urine volume is less but the concentration is very high. So this is another important function of angiotensin II. Now come to the third factor other than neural and the hormonal factor is the autoregulation. When kidney is perfused at moderate pressures, that is in between 90 to 220 mm of mercury, the renal vascular resistance varies with the pressure so that renal blood flow is relatively constant and GFR, it is also constant. So this autoregulation, we can explain it via two theory. One is the myogenic theory, another is the tubuloglomerular feedback. So in the myogenic theory, it is said that when the arterial blood pressure it is raised, so there will be increased afferent arteriolar blood pressure. So the arterial wall will stretch, sensing by the myogenic stretch receptors, opening of voltage gated calcium channels, influx of calcium from extracellular fluid into the vascular smooth muscle cells, contraction of vascular smooth muscle cells, vasoconstriction, minimizes the changes of afferent arteriolar blood flow and minimizes the changes in GFR. So now the So we can say that when there is stretching due to increased blood pressure, when there is stretching of these blood vessels, that will induce the vasoconstriction, and as a result of that, the GFR will be restored. Now come to the tubuloglomerular feedback, how it is happening. So this tubuloglomerular feedback, it is mostly due to the sensor action of the macula densa. The amount of fluid entering into the distal tubule at the end of the thick ascending limb of loop of Henle depends on the amount of sodium and chloride, Na plus and Cl minus ion into it. So this is the macula densa cell. So they will sense the amount of Na plus and Cl minus ion that is present in the distal convoluted cell. If more filtration is there, that means there will be more sodium and chloride available. Now this Na plus and Cl minus, they will enter the macula densa via this Na plus 2 Cl minus and Na plus K plus 2 Cl minus co-transporter in their apical membranes. The increased Na plus causes increased sodium potassium ATPase activity and the resultant increase in the lysis of ATP. So there will be increased ATP lysis and there will be formation of ADP, and from this ADP there will be production of adenosine. It is secreted from the basal membrane of the cell. Now it acts on the adenosine A1 receptor on the macula densa cells, and it will increase, there will be increased release of calcium to the vascular smooth muscles in the afferent arterioles. This causes afferent vasoconstriction and the resultant decrease in GFR. So when there is increased GFR, more filtration of sodium ion and chloride ion, there will be more entry of these ions via this co-transporter. So there will be more production of adenosine. Adenosine bind with adenosine A1 receptor in the macula densa cell, and the release of calcium to the vascular smooth muscle in the afferent arteriole, and as a result of that there will be afferent arteriolar vasoconstriction. But another factor is also important factor is there. So we know this that the similar mechanism generates a signal that decreases the renin secretion. So there is increased vascular smooth muscle contraction and the afferent arteriolar constriction is there. And at the afferent arteriole we know that there is juxtaglomerular cells which can secrete the renin. But what will happen? The similar mechanism generates a signal that decreases the renin secretion by the adjacent juxtaglomerular cells in the afferent arteriole. So it is causing the vascular smooth muscle contraction at the afferent arteriole, and it is preventing the renin release. So this mechanism is known as the tubuloglomerular feedback. Conversely, an increase in GFR causes an increase in the reabsorption of solutes and consequently of water, primarily in the proximal tubule, so that in general the percentage of solute reabsorbed is held constant, and this process is called the glomerulotubular balance, and it is particularly prominent for Na+. Now few physiological conditions that may alter the GFR. One is exercise. GFR decreases in exercise due to sympathetic stimulation, and the pregnancy, in case of pregnancy, the renal blood flow and GFR both they increase. Renal blood flow increases due to increase in blood volume. Then the posture, in standing position for a longer duration decreases GFR. GFR is usually less during sleep due to decreased circulatory activity. Whether GFR is more in rainy season and less in summer. Gender, GFR is less in females, and GFR decreases in geriatric age group due to functional loss of nephrons. Thank you.